I really enjoyed that last talk. I think it was just really just right spot on. And I learned so much, and it integrates a lot with some of the work we're doing here in St. Louis on another level. So thanks for inviting me for this conference. As Dr. Chan mentioned, we're going to talk about diversity and inclusion in the rheumatology division. What you can do to enhance diversity and inclusion and culturally appropriate practices in rheumatology. I have no financial disclosures, and 1 second. And here are our objectives. We're not going to spend a lot of time talking about pluralism, cultural diversity, and inclusion. You're a sophisticated audience. You got that. So what I would prefer to spend my time on is really talking about how diversity really can promote a very inclusive healthcare workforce that can begin to address some of the health inequities, and then to provide some examples of strategies that you can use to enhance diversity and inclusion among rheumatologists. And ultimately, we all want to enhance diversity and inclusion at academic medical centers. Now, since this is a rheumatology talk, and since Dr. Chen and I were in medical school together, Andy, this is actually the first patient I saw when we were taking Introduction to Clinical Medicine in 1981. This was actually, I was mentored by Dr. Nancy Heron, who was a rheumatologist. This is my first patient, and you can see the hands of a patient who has rheumatoid arthritis and all the synovial thickening and stuff, the subluxations and all the other features. What was unique about this patient was that he really didn't have a provider who understood the difficulties that he faced, just going and doing the usual activities of daily living. And I remember he was just concerned that everyone was looking at his hands and no one was really looking at him as a patient. I think that was a lesson I learned more so than subluxations and rheumatoid arthritis. And it caused me to really reflect on what we're doing in academic medicine. Sure, we're doing a great job of fulfilling our tripartite mission of clinical research, clinical work, research, and education. But should we have a larger goal of promoting community health and closing healthcare gaps? And I don't think this is a pipe dream. I think this is something that we really can aspire to. And so now, why? Why is that important in terms of trying to diversify the workforce, and particularly the rheumatology workforce? Here's data from the U.S. Census showing information that we all, of course, are aware of, that by 2044, the minority population will exceed 50% for the first time. At certain states, California and Texas, we're already there. And the comments have been made that we need to move a little bit more rapidly to accelerate a professional workforce to attend to the needs of this population. This more minoritized population will be a majority population by 2044. Otherwise, we're going to have a perpetuation of these disparities. And yet, despite all our best intentions, we haven't done a particularly good job as a country. This graph actually shows the percentage of underrepresented minorities in medicine from 1950 to 2000. And you can see that this number was relatively flat until the civil rights movement in 1970, when we actually began to increase the number of URM matriculants in medical schools. However, that number remained largely stagnant until 1990, when there was a national effort called Project 3000 by 2000, trying to increase US matriculants by the year 2000. But that also was short-lived due to mostly a number of national legal attacks on affirmative action and other issues. And so we kind of left with this period of stagnation. Maybe I should go so far as to say a period of regression. Interestingly, the data said from the WMC in 2014, there are fewer African-American males enrolled in medical school in 2014 than there were when I enrolled at Washington University in 1980. That's stunning data. And it really just shows that we have really been not forthright in advocating for diversity in medicine. Here's a graphic that actually is a combination of a number of data reports, census data, CDC data, and Kaiser Family Foundation. And it just shows you that attrition over time, going from 13.4% of the population for African Americans to 5.1% among residents, and then the further attrition. Currently, only 2% of professors in academic medicine are African American. When we look at graduates who are graduates who are actually practicing, those numbers are really vanishingly small. Here's data from the U.S. from the WMC time period 1980 to 2012, and kind of hugging the axis here are the African American men and women, and you really can't see them. The African American men are in the dark gray, and women are in the dark black, and they pretty much, you can't see them because they have been unchanged since Dr. Chen and I started medical school in 1980. This is abysmal. This is unconscionable, and it really begs that we actually have a really cohesive, coherent national approach to diversifying our ranks. As we ascend up the academic ranks, we see this continuation of this disparity. Now, here we're looking at faculty stratified by race and ethnicity, and we can look at the top line here, the blue squares, and you can see, yes, we do seem to have made some improvements. These are the junior faculty, the assistant professors. Below, you can see, in fact, let's go to the nadir here, which is our African American professors, and you can see for the most part that number has been largely unchanged. Modest improvement from 2% in the 1960s to only 4% now. What's happening in rheumatology? This is data from the 2015 workforce study of rheumatology specialists in the United States, and it was equally sobering. If we look at the adult rheumatology, these are all members, your colleagues. You may have participated in this survey, looking at data by race and ethnicity, and unfortunately, among adult rheumatologists, only 0.8% were African American. Again, these numbers are staggering, and they're sobering, and again, they're unacceptable. What's happening in rheumatology? Essentially, the same trends that are affecting your discipline are the ones that are affecting my discipline and nephrology and others. I think they're pretty much unchanged for the most part. If you look at the supply-demand curve here, you'll see that our supply is really affected by the rheumatology providers, the current providers who sometimes age out, they retire, demographic changes that we just shared earlier, showing the growth in communities and members who are from underrepresented groups, the changing workload and practice settings, how so many individuals are moving out of academic medicine to practice and retiring early. And then the demand, of course, what are those factors? Let's talk about the prevalence of rheumatic diseases, particularly among individuals who are African American or Latino. We have healthcare usage trends, the changing demographics, the aging of the U.S. population. All these things increase demand, and again, they're not commensurate with the supply. And this imbalance is reflected in what we see here in contemporary U.S. Now, I think it's important to really ask what are some of those disparities, and I think this helps make the case for more egalitarian practices and bringing in physicians of color to attend to these persistent, intractable disparities. A study by Greenberg, published in 2013, a large cohort of patients with rheumatoid arthritis showed higher levels of disease among Hispanic patients and lower levels of remission among African American patients. And so we have this group with active disease, just like the patient I showed you, that index patient I saw in 1981, patients with severe crippling arthritis, and inability to access providers who truly understand that patient, their disease, and most importantly, understand all those other factors I was alluding to with my index patient, the social and structural determinants of health. I know when you see that patient and you ask, my goodness, I mean, how does this patient navigate? I mean, how do they even push a lawnmower? How do they get through the regular day? And who's there to really help them navigate care? This is particularly important when you see these lower rates of remission of rheumatoid arthritis. Similarly, a study conducted at Rush University. Rush is pretty much, it's a safety net hospital system in Chicago, right in the heart of one of a very disadvantaged community in Chicago. And in that study about Riyadh, in terms of a median time to first rheumatology visit, there was a gap between Hispanic patients and other groups. Also, Hispanic patients were less likely we actually had a larger time before their first rheumatology visit and the development of their chronic rheumatological disorder. And Black and Hispanic patients had higher routine assessment of patient index data and higher SED rates compared to other groups. So what do we do? I think it's important to really step back, not just for us in our division, but for us in general in medicine per se, and ask, are we crafting mission statements that state this need to expand and bring in patients, rather providers, physicians, researchers to attend to this increasingly diverse patient population? Is it really embodied in our mission statements about creating, and here's our mission statement at Washington University, creating a culture that supports diversity, inclusion, critical thinking, and creativity? I think we have to state this explicitly up front if we really are going to be sincere in galvanizing our academic medical centers to address these really, really difficult issues, and stepping out and making bold claims like this. Improving cultural diversity within the academic workforce should not only be a 21st century moral imperative, but a centerpiece in our national effort to eliminate health inequities. And so let me now pivot. I'm going to spend the next 3 minutes really talking about why we need to have diversity and inclusion. Then I'm going to talk we're going to get more granular and talk about the things, really the active plans, the objectives and plans that you can do as rheumatologists to promote diversity and inclusion among our ranks. Again, this is a really sophisticated crowd. I don't need to talk about a definition of diversity and inclusion. I think you get that. And I think we certainly understand why we need to do this. I don't need to highlight these reasons. They're pretty obvious to all of us. You should look at them and understand why, but I don't need to read those. What I do want to state is that irrespective of where we are, whether we're in academics or whether we're in business or whether we're in law, whether we're a phenomenal physician scientist like my colleague Dr. Chan, or someone working in a residency director, we have to ask, what are we trying to do? Essentially, we can, compartmentalize diversity, along certain uh, 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 ideas or certain values and problems and issues of viability that we're trying to achieve. And I say compartmentalize because we have to, again, step back and say, certainly we want to do this for the larger good of society, but within our ranks, within our professions, what does diversity do? What are we asking it to do? And we have to start thinking about these social and moral issues and performance issues. And then I don't always talk about this, and some of you are certainly probably your leaders, your resident directors, division directors, maybe probably some department heads on this call, on this meeting. I think it is important to highlight the business case that when we have a diverse group of individuals, whether they're students or residents or fellows or faculty, that diverse group outperforms a non-diverse group all the time. And that holds true in other fields outside of medicine. I mean, the data is pretty stunning that diversity truly matters because diverse groups outperform. They outperform in financial indices, they outperform in research, they outperform in clinical areas, they outperform in education. They just really make a difference. So let's now pivot and talk about the things that we must do and to really fulfill our obligations to society, social contract to society, in providing a diverse workforce, which can attend to the increasingly diverse population of this country. So first, I start talking about mission statements and vision statements, and many people say, "Well, those are just words." Will, I mean, no one reads that, and I dare say that's not true. If you really want to know what people believe in and what they're doing, you go back and you ask them to put it on paper, and you come back year after year and you hold them accountable to what was written. I think it's absolutely critical. And so I ask all of us to go back and look at, what we're saying on what we're putting out on the websites of our divisions, departments, what we're putting out on our websites of the school. Are we actually addressing those issues of diversity? Are we identifying the strengths and challenges? Do we have clear metrics for success? If we're talking about recruiting in a diverse workforce, and you say, well, within one sector, one division at UCLA and rheumatology, the workforce is 1.5%. Well, what are your goals? Are you trying to get to 3%, 5%, 6%? It's really important that we maintain some transparency here, that we actually create a scorecard and share that. We talk about, here's what we're doing. Here's our plan for the next 3, 4, 5, 10 years. We have to hold ourselves accountable. And we have to embrace, in order to do this, we have to embrace pipeline approaches. We have to recognize that, unfortunately, there are too many people in the ranks that many of us hold in senior leadership and senior members of the professoriate. And we just have to create pipeline programs to bring in some new faculty. And we're going to talk about those in a few minutes. Those pipeline programs really have to span the gamut from high school to residency. And that means that when we engage in high school pipeline programs, we have to realize that the return on that investment, it's not going to be immediate. And we have to be patient. We have to shore up those pipelines. We have to fund them appropriately. Give an example, we created a pipeline program here in St. Louis, and Andy mentioned the Collegiate School of Medicine and Bioscience. We were tired of hearing that St. Louis public schools are underperforming, that we can't find African Americans who are ready or who are academically prepared for the rigors of intense university studies. So we said enough of that. We're going to create our own school and our own curriculum and move those students along. And so I advocate for that. This is high level commitment, folks. And it's high level of commitment that isn't going to reap those dividends in 2 years. And similarly, we have to have those same pipeline programs at the undergraduate level, the medicine school level, and the residency level. A couple of examples I'm going to go over. Looking at clerkship programs, looking at creating a network associations and affinity associations for residents and fellows of color. The medical student elective program is really, really effective one. We established one in 2007 and found that 21% of our students have been accepted to residency programs here at WashU. Wouldn't it be nice to actually structure an elective program in rheumatology and really highlight that and get the best students across the country at your particular institutions in rheumatology? We have to also recognize that we need to demonstrate that we have a critical mass within our communities, because no one's going to want to come in and see 1 or 2 people of color and say, oh, this, they really want me here. We have to show some sincerity by having support of the critical mass. And we created an organization here, the Washington University Minority Medical Association. These residents and fellows will meet with prospective residents and fellows of color. And it makes a difference when they come in and they see faces like this that look and sound like them. And we have to actually provide some support, financial support for those residents and fellows who are interested in scholarly endeavors that promote diversity and inclusion and community engagement. When we did this at Washington University, creating this Washington University Diversity Initiative, we were able to see a remarkable increase in the number of residents of color within our ranks within only a 2 or 3 year time period. The point is that these work. These initiatives work, and they can work in the rheumatology division. Also, we have to bring our residents and fellows of color back on campus. Those students, rather, who are considering applying to your residency to residency programs and others, we have to bring them back and talk about these things. And so when this happens, you should be aware. You should say, well, I want to be part of this. I want these students to understand what's happening in our rheumatology division. Also, we have to work with our hospital partners to ensure that they, that when they come in, they can be aware that there is a network and support on our campus. Let's move on. I want to really leave ample time for questions here. That is, the next stage is really developing some targeted interventions for faculty. Again, I showed you the data from the rheumatology survey that 0.8% of respondents were African American. That is woefully inadequate, but you can't recruit from among that small group. They're just you're robbing Peter and you're playing a shell game, moving people around. We have to have more active programs, working guidelines for faculty searches in rheumatology. We created a diversity scholars program here at Washington University where faculty would come in and would be given protected time and substantial funding, bridge funding until they were able to acquire R01 grant. We're hiring the best faculty based on who we know, recognizing that we may not always have a position, but medicine is interdisciplinary. They can come in and become a faculty in immunology and even pathology if they have an interest in rheumatology. We have to start thinking creatively, and we have to provide, expand our network of diverse faculty. All of you should be creating, I presume you already have visiting scholars program, or you bring in the few prominent faculty we have of color for grand rounds and residence reports and other such name conferences. We have to do more of that, and realize that even if we do that, we have to change the culture of our institutions. They have to be appropriate because many individuals will come in and find our academic centers and our clinical practices unappealing. So now let's go through what I'm recommending to you to improve diversity. And I have rheumatology residents here, but let's talk broadly about rheumatology workforce in general. First, if we're not out there actively recruiting, then we're working passively, and we're just assuming that students and residents and fellows who are interested in rheumatology are going to just simply and naturally gravitate toward us and our institutions. And that's not really the case. That we have to be visibly present on the road sometimes, recruiting at groups such as the annual associations of the Student National Medical Association, Latino Medical Student Association, Asian Pacific American Medical Student Association. At our institution, I frequently have residency directors from rheumatology, radiology, surgery accompany me at these events, and it makes a difference. They're talking about their particular area. They're going to talk about rheumatology and all the support and the diverse patient mix they have to learn, and it just makes a difference. Number two, I alluded to these pipeline programs that we need. They're really important. They're really critical to encourage the numbers of individuals to pursue medical careers. One opportunity, and I love to get some feedback, is to create a summer research program in rheumatology for undergraduate and medical students. We have a number of these programs across the country. Some are NIH supported, some are institutionally supported, and they, again, make a difference. Even if you bring in a small cohort of 3 to 5 undergraduate students in a rheumatology laboratory over the summer, and you get their interest, you excite them about all the things, fascinating things that are going on in your field. And these are the ones who are going to more likely consider pursuing careers in rheumatology. We have to, I also alluded to the visiting elective program that we started here, and there are many across the country. But we have to start creating more targeted programs where students of color can rotate through rheumatology departments, giving them that exposure and jumpstarting their career in rheumatology. I certainly know we have the capacity to do that work, and we've created that infrastructure. I think this is something that we can start fairly soon. Number 4, I also alluded to our residency recruitment programs. Rheumatology has to be visible in those activities. I know they're carried throughout the country, but we need to become much more involved. And then let me conclude by talking about a really critical part of recruitment, and that is the actual environment, the cultural environment. If we're committing to this, we have to identify liaisons in rheumatology on our campuses who can work on search committees, who can work on all these pipeline programs, who can create mentoring networks on our campuses. If we do this, I think that we're going to create this remarkable interest. We'll see organic growth, and we'll be able to move that needle beyond that 0.8%. I'm passionate about this. Thank you for giving me this opportunity to really highlight some of the initiatives that we can be engaging in right now, this day, to enhance diversity in rheumatology.